first of 4 that we have scheduled throughout the year for everyone here. We do have a few individuals on the phone, so they will be participating remotely and over chat, just so you all know, and we will be recording the session, so it will be posted to the resource page, which I'll go over in just a bit. I just want to thank the New Hampshire Hospital Association for hosting us all here today, and for our presenters from 2 of the communities here in New Hampshire who are going to be sharing their experiences with our topic today. And I will dive right in. So we will be talking, obviously, about recovery coaching in emergency rooms and implementation in the state. And I'll introduce myself. So I am Melissa Schammel, and I work for the Community Health Institute. And I've been working at the Community Health Institute since 2015, and a large part of my work there is with the Center for Excellence. I'm sure some of you have heard of that before, but largely my work has been on the prevention side, so I've kind of been working with the continuum of care, but mostly on prevention. And as you know, the center has been contracted with the Bureau of Drug and Alcohol Services to coordinate this community of practice, and similar community of practices throughout the continuum. So we have treatment, MAT, and one for prevention professionals as well. I'd like to introduce my colleagues as well. Adelaide Murray in the back of the room, and Rekha Sridhara right up front here. Addie and I are the leads for the 4 communities of practice that we have. I lead the recovery community of practice and the prevention community of practice, and Addie leads the treatment and the MAT communities of practice. But we are work very closely on both of them, so both of us could be a resource to you. I would be the primary, and if I'm not available, then Addie definitely knows. But we do all 4 of these under the guidance and support of Rekha, who you all have worked with before. She led the recovery communities of practice previously and is guiding us as we fly our wings and become big birds in the big world. Thank you, Rekha, for your support. We also have a very extremely active planning team, and everyone, I believe we're only missing one here in the room today. We have Cheryl and Polly from Harbor Homes, and Lindy Keller from the Bureau of Drug and Alcohol Services on our planning team. We also have Keith Howard from Hope for New Hampshire, but I don't think could be here today. Just a brief overview of what our agenda will look like today. Once I'm finished with an overview of what the PRSS community of practice looks like in general, Cheryl and Polly are going to dive into what recovery coaching is, and specifically recovery coaching in the emergency department. And they'll introduce our 2 guest presenter communities from the Lakes region and from Stratford County. Our guest presenter communities have implemented recovery coaching in the ED and will be sharing their experiences with implementation from the recovery community organization and the hospital perspective. And we will have presentations from Navigating Recovery in the Lakes region, followed by SOS Recovery Community Organization and Wentworth Douglas Hospital. So thank you guys again for being here. After those presentations, we will break into small groups and discuss our own experiences with this topic, successes, challenges, and strategies that have been successful. And before leaving today, we hope that you will complete your evaluation that you have in your packet, and as this will be required for CEUs, credits for CRSW and for LADAC. For those joining us remotely, we'll be sending the evaluation via SurveyMonkey link. All right. So what is the community of practice for those who haven't participated before? It refers to a group of people who share a commonality, a common passion or work for something that they do, and they interact regularly to learn how to do it better. And the goal for today and for this community of practice is to gain knowledge and share information related to peer recovery support services. So again, the purpose is to bring together those delivering peer recovery support services with the opportunity to connect in developing quality PRSS services. And as members of this community of practice, you will have the opportunity to receive and engage in in-person meetings like today, resources and tools that are on our website and through an email chat, the Google group, which I'll get into, and you might have received an email from me yesterday about, individual technical assistance through the New Hampshire Center for Excellence, and other resources as needed, such as conference calls and other opportunities for sharing. So the first resource I wanted to go over with you today can be accessed on the New Hampshire Center for Excellence website. So that's www.newhampshirecenterforexcellence.org. And under the Resources tab here, there's Community of Practices resources. And under that is the PRSS Community of Practice resource. Oh, thank you, yes. So on this PRSS COP page,
Is that okay with everybody, just so you can see the slides better?
thanks, Polly. You'll find the meeting schedule for our in-person meetings, where they'll be held. We're at the New Hampshire Hospital Association today, but our next meetings, the next 3 meetings, will be at the New Hampshire Training Institute in Attica. Just so you're aware of that, and that information will be posted on the website. There's also links with information about the accreditation process and past meeting materials, resources including slides, any handouts, and the recordings. So if you haven't checked it out, it's a great resource to have. And there isn't a password to get onto that page. The second resource I am going to go over today, and Reka is going to come up and give a little tutorial, is that you will have access to, and but if you want to use, you can opt out, is the PRSS Google group. So this is an email-based distribution list that will replace the web-based discussion forum that was previously on the center website. So you've had a login, and it just wasn't used. It's a little hard to get it into the workflow, and wasn't as user-friendly. So the discussion forum has been deactivated, and this Google group is going to replace that discussion forum. So we decided to move to Google Groups because we feel it's a better opportunity for sharing among the COP participants, and it has been used successfully in the MAT and the treatment communities of practice. It also offers the opportunity to archive conversations. So if you see an email go through and you know that there was a topic discussed in that community of practice or resource shared, it will archive all that information for you, and Reka will show you what that will look like. So you don't have to go through your email box to find past conversations. They'll all be there for you. So the email group will keep you informed about upcoming in-person meetings, trainings, and other events related to PRSS, news and publications from the field. Anyone can share an event using that email, prsscop@googlegroups.com. If you email it, it will be everyone that has accepted that invitation to join. You can ask questions of other members and like I said, share events and information. So there's 2 ways. You can reply to an email, reply all, so that will include the PRSS COP, or you can post a question by just emailing that. So everyone should have received an invite to the Google group yesterday. I sent out it to everyone who was invited to this PRSS. So if you haven't received it, or if you did receive it, please accept it if you want to participate. You can decide not to participate and want to participate later. You're not like out for life. And you can manage your settings to receive emails as they come in, or at a weekly basis or a monthly basis, however it works for you. If you don't want to get an email, a notification anytime one comes in, then that's fine. You can have it at a weekly kind of alert. You can kind of see what the conversation has been over the week and participate. If you, like I said, if you didn't see that email invite in your mailbox, but you'd like to join, email me after today's meeting and I can add you. Or if you have anyone from your organization that you think would like to join, or anyone in your community that you think would benefit from participating, send me their email address. So I'm going to pull up what it looks like and have Reka go through that with you and fill in any details I might have missed.
You know?
So Google Groups, if you're not familiar with it, it's very much like email. It's pretty much no different. The only difference is that it archives all of the materials and questions and things that are shared through this group all in one place. So that's the nice thing about it, and that's why I love it, and tried to push towards going this route versus what we were previously using. So this is what you'll see once you join. So if you accept the invitation that Melissa sent you, it will ask you to provide some details, but then you'll have access to this main, what they call a homepage. And so Melissa sent a test email. So basically, all emails that come through, you'll see like this. So it'll just be a running list of different emails. If you're sharing, say, information about an upcoming training or a specific question for other participants of the group, it's always good habit to label your email with specifically what it is that's in the email. So keep it brief and title it in a way that says, I don't know, Recovery Coach Academy training or something like that, you know, just so that people know what that email is relating to. So you'll have a running list here, and then you can just simply click on it, and you'll see the actual email. It'll look exactly like an email, and then you can choose to respond or not do anything. And then in a future, you know, later date, if you remember, like, oh yeah, I remember somebody shared information through the Peer Recovery Supports Community of Practice, you can simply go to this page and find it. You don't have to save the information anywhere else. It won't delete from your box. What I do is I save this as, so I bookmark it as one of my favorites, so that way it shows up on the top of your browser toolbar, so then you can easily access this page going forward. You don't need to remember, you know, like a username or a password or anything like that. You just have to click on your page. And then if you're part of other community of practice Google groups or any other Google groups, that'll all show up on the left-hand side of your screen. So you can see that Melissa's part of the Peer Recovery Supports Community of Practice, but also the SUD Treatment Community of Practice. So all of your other groups that you're part of will show up there as well, and you can toggle back and forth through each of those groups. If you don't want to go through this page to email someone, you don't have to. You can just simply open up a new composition on your email and then put in the email address, which Melissa said was prsscop@googlegroups.com. And so you just put it in as if you were simply emailing, you know, someone. So use that email address, and then you can type your message, and then it'll automatically send to everyone that's part of that group, but it will also save in your main homepage. So it's exactly like an email, but the nice thing is that it archives everything for you. And then you can set it up to, so if you want to receive emails every day, you know, as they come in, you can get those emails. If you decide that you get a lot of emails and you just don't want to receive those every single day, then you can set it up to come in weekly or even less frequent than that. So there's that option too. So you have the ability to, you know, really customize it to whatever your needs are. And so basically at this point, it's just accepting the invitation, and then if you have problems with, you know, how to use it or how to send a message or anything, feel free to get in touch with Melissa or Addie, and they'd be happy to help you figure out how to navigate this. But hopefully it works for you, and we'll pilot test it for 2 months, see how it's working, and then, you know, we can go from there.
Thank you, Rita. She's more familiar with it because she has been doing it for the other 2 communities of practice, so I appreciate her kind of going over the details.
All right. So the last resource that I'd like to go over with all of you today is the technical assistance that the Center for Excellence provides. And there's 2 ways to request technical assistance. On our webpage, it's a form that you'll fill out, and just note that in order to receive the highest of quality of technical assistance, we really need all those details in that request so we can respond timely and figure out what the need is and identify what that request is. Requests will be reviewed by the center and sent to the Bureau of Drug and Alcohol Services for approval before it is approved, but that process takes around 10 days at most. And for those who might not be aware of when I say technical assistance, what that is, we support in the development of trainings, facilitation, support some strategic planning. We can do on-site consultation, data evaluation, so data analysis and evaluation planning. So we do have a running list of things that the center can provide, and just work with you and the Bureau to make sure that those needs are met. So use that resource, and if you aren't sure what your request is or want to hash that out, feel free to email myself or anyone from the center team here to kind of hash that out and what that technical assistance request should look like, and we'll be in touch with you. So, in lieu of asking everyone here today to introduce yourselves, I'm going to provide a brief overview of who's in the room. So we have about a third of the people here are CRSWs, and we have 13% here who are working towards their CRSWs, and 38% are recovery coaches, and the other 30% would be LADACs, licensed clinical mental health counselors, and nurses. So a good group, a wide variety of people in the room here. And then we also have representation from some varying settings. So please raise your hand if you fit into any of these buckets. So the Regional Public Health Network bucket, hospitals, the Bureau of Drug and Alcohol Services, family resource centers, recovery community organizations, mental health centers. So a good group, and thank you all for being here. Are there any questions regarding the community of practice before I dive into what our objectives are for today? Okay. So our objectives are as follows: to identify the components of a comprehensive recovery coaching program in the emergency department setting, to list steps taken to implement recovery coaching in the emergency department, and to describe lessons learned and barriers experienced from early adopters. All right, thanks again for being here, and a reminder to complete your evaluation before you leave today. I'm going to do another reminder at the end, so please be sure to do that. So, Cheryl.
Okay, hi everybody. So I'm Cheryl Pasquelli. I am the project director with Harbor Homes that oversees the 9 recovery community organizations with 11 recovery community centers. So 2 of the centers we oversee have been doing this program in the ED for quite a while with, you know, some bumps in the road and some smooth successes, and we asked them to come here to talk to you about that, so if you in your program wanted to do it, you could learn from their mistakes as well as their successes. But before I do that, I want to take a minute to tell you, take some of these drug disposable bags, as many as you want. We have a whole case of them in the back there. And to let you know that just, you know, by chance, last night a report came out called Recovery Coaches in Opioid Use Disorder Care, and it was prepared out of Massachusetts. And although it really doesn't have data, it does show that there is some effectiveness. There's no standard outcome measures as of right now to determine that, but I left some in the back, and Melissa is also going to email you the link to this, so you have it if you're ever writing a grant or anything. This may come in handy. The other thing that I just want to make sure everybody understands what this is, I left one of these, which is called Recovery and Recovery Supports in the Granite State. No. So this report was 18 months of work on the Recovery Task Force to finally write something down, and it talks about the growth in peer recovery support services since 2014 to, I believe, this went through November of 18. So many of you in the room are responsible for the work that we were able to capture for this, and I just wanted you to have this, know it's available for you to use, and, you know, spread the word of all the good work that all of you are doing. So, I think I have some slides. Now I'll try to get back with the program. Go ahead.
Cheryl, is this posted,
Um,
Recovery Hub,
I
for people
believe,
that may want to share it electronically?
yes, we're going to send it out in this too,
Okay.
but it's gone to Randy, so,
It just goes to the blog on the Recovery Hub right now? Okay, and the Recovery Hub is, the email for that is on the front of this page, so if you want it. And there's also a longer report.
that's not in the final
That's
version.
still, okay.
Yeah.
Can you send it
Easy does it,
electronically?
Lynn. What?
Can you send it electronically?
Yes.
We can post it?
Yeah, yep, happy to. Yeah. Wendy, that might be next year. Longer.
We'll get it up
So-
on the Recovery Hub.
Yes, yeah, we'll get that done. I'll make
Yeah,
sure.
you're saying it's already up on the Recovery Hub.
Yeah, it was on the Recovery Hub later than that.
So Recovery Hub, nhrecoveryhub.org is already posted, so you can forward that.
From there. I'll verify that while we're listening to our speakers. Okay, back to the program that we came here for. So emergency department recovery coaches are trained, typically CRSWs, are being used in this setting for people who are admitted for either SUD or opioid. So what does that look like? How does that work? Are you staff of the hospital, staff of the recovery center? What trainings do I have to go to? How do I get a badge? How do I get in? How does the nurse at the desk know who I am? We're going to talk about like all of that today from the people who are doing it. So give me another slide. So typically the recovery coach will meet the person in the ED setting and then follow them, if they choose, a path through the recovery community center that's local to them. So the first touch point is like a touch point of hope. You know, there are people out there that can help you. We want to help you, and breaking down the stigma barriers and those kinds of things are what that recovery coach can do in that first touch point. So we have two groups of leaders doing this work in New Hampshire, and so I'd like to welcome John Burns and Kelly up, and Daisy and Marge. Come on up. And they're going to, like, give longer introductions of themselves, so. And I think we should turn the lights on. I don't know, we'll see. Come on up. There you go. All right.
Lights on, lights off, well, then we can't see the speakers if we have the lights off.
Yes.
But I think you read.
Okay.
Screen's probably more entertaining.
All the information's up there.
Okay, you might need to turn it that way.
Okay. So why don't we start with introduction?
Okay, so my name is Marge Kearns. I'm a pharmacist by profession. I'm currently the Vice President for Clinical Services for LRG Healthcare, which is both Lakes Region General Hospital and Franklin Regional Hospital. You'll see in one of these slides, we say you need a senior champion, so I guess I'm the senior champion of this program. I've been with the hospital in multiple roles for 26 years, so going on 27. So I know a lot of the players, which I think was helpful. So I will talk to you about how this got started, but I was the one that first got involved with the Foundation for Healthy Communities, so I oversaw this project that we have, which was funded through that, and I'm also will be the co-administrator. I gave myself that title. No, nobody gave it to me. Co-administrator for the Doorway at LRG Healthcare, which is the Hub and Spoke program. So.
And I'm Daisy Pierce, Executive Director of Navigating Recovery of the Lakes Region. I have been with the organization since we were just a grassroots group meeting in a church basement. And now we have a recovery center that's been open for just over 2 years in downtown Laconia. And one of the very first projects we actually did after we opened our doors and started providing services to our community members was link up with the hospital to do this recovery coaching in the emergency department program. So do you want them to introduce themselves now or wait until? Yeah, introduce yourselves and then you can.
Okay. I'm John Burns. I'm the director for SOS Recovery Community Organization. We have 2 centers. We have one in Dover, New Hampshire, and one in Rochester. Rochester opened in September of 2016, and Dover opened in April of 2017. And we've been doing the coaching at Wentworth Douglas since April of March or April of this year.
I'm Kelly Mueller. I'm the Director of Behavioral Health Services for Wentworth Douglas Hospital. I've been with the hospital for a little over 20 years. Started in the social work department, worked there for about 15 years, and then our hospital recognized the need to build behavioral health services for our community because there weren't enough out there. So have been working on developing and implementing behavioral health programs in our health system for the last 6 years. And the Doorway in Dover at Wentworth Douglas Hospital falls under me in the behavioral health department. So now I'm doing that as well.
Thanks. Okay. So do you want to start with the grant?
Sure. So, so I told you I'm the senior leader at this point. I was in a different senior leadership position when the grant first came to me. I inherited it actually from the CFO, who was the one who interacted with the foundation most often. And so I didn't really know what I was inheriting, but I learned. So this was back in the beginning of 2017. And I think it's a couple of things I'll mention about that. I think it was coincidental, but I think in hindsight, it was really a good idea to give this to someone who was going to end up in the VP of Clinical Services role. So if you look at our senior administration, there are 3 clinicians on that. There's a CNO, a CMO, and myself. And so and I've noticed this with other initiatives in the hospital, if it goes to the CNO or the CMO, it's a more siloed approach. If it goes to the VP of Clinical Services, there's really no barriers, and I pretty much go wherever I want. And so that, in addition to knowing the players for as long as I did, I think helped get this off the ground. So we first had to sign an MOU, Memorandum of Understanding, with the foundation to say, okay, what are we going to use this money for? And so we got a separate grant for Lakes and a separate grant for Franklin. Had to sign the MOU, and the MOU, the real purpose of the grant was to decrease it. They didn't say, the foundation didn't say you have to have recovery coaches in the ED. Basically what they said was you're going to reduce stigma, and you've got to support your patients coming into your emergency rooms, okay? And it's up to you to figure out how to do that. And so I remember the first day I met Daisy, and I met her with Jackie Abacoff, who runs Horizons Counseling Center. And, I mean, I was trying to learn as much as I could, and they knew a heck of a lot more than I did. So it seemed like a good fit to say, okay, they can be helpful with, if we put recovery coaches on call in our emergency rooms, that looks like a good step in helping to support. and what you'll see through this is also helping to reduce stigma as time went on. And so that was the first thing, the MOU with the foundation for the money, okay? And then we needed a separate MOU with navigating, and we had also hooked up with another recovery support center that we really never were able to get it going with them, and so navigating became our recovery center for both Lakes and Franklin. And what we did with that was we said, you know, at Lakes, a recovery coach, when called, will show up within 30 minutes. At Franklin, a recovery coach will show up in 60 minutes. And for any of you that have been to an emergency room, you got plenty of time if somebody shows up in 60 minutes, okay? Even though we're working on that. But so that seemed to work. And so that was the MOU with navigating. We had to decide, okay, what's going to happen, who's going to call them, you know, what the fee service would be, and that was all built into the MOU. And I know Daisy will jump in if I miss something. But basically, the thing that we found, and I'll let Daisy tell it from her coach's perspective, but, you know, the first hurdle on this was the human resource. You know, how do we get these people to pass the whole HR process, which, you know, in any hospital, there's definitely a lot of hoops. And so we had to really work with HR to try to simplify what we were requiring, you know, still follow the regulations, but what are we requiring for a recovery coach? Can we simplify that in any way from an employed person? Because this was basically a contract, right? It was a memorandum of understanding. And through CMS, which is who accredits us, ultimately, you still need certain regulations followed, but which ones could we massage a little bit and still manage to appease the regulatory bodies? And so our HR senior VP was instrumental in helping us through that. And we were fortunate to have a grant because a lot of the things cost money for labs and that sort of thing. And so we were able to reimburse, you know, what our occupational health service would do is they'd send the invoice to me to be paid out of the grant versus to Daisy, who really wouldn't have had the funds to and they did that at cost, so that was good. So it kind of saved some of that grant money. So
some of the things that were included in the HR process were a physical, TB test. They had to have their immunization records, and they also had to have a drug screen. So when you talk about all those things combined, it starts to add up pretty quickly. And the coaches certainly weren't going to pay for it. We were a brand new recovery center that didn't have that kind of. And so the grant was able to pay for that HR process, which really helped quite a bit.
And so, you know, that's really, had we not had the foundation grant, this would have been a really hard thing to implement, even from just a cost perspective. The other thing is badging. I think somebody mentioned badging. And so how are these people going to be identified? You know, they have to have some sort of a badge, and we got through that hoop with security so that people got badges so that when they showed up in the emergency room, it was apparent that they were supposed to be in the emergency room. You know, they were contracted to be in the emergency room. The next thing is, you know, what's the policy, right? Hospitals love policies. And so we wrote a policy really not knowing, quite honestly, how this thing was going to work. So we did our best to throw down the steps, which kind of when I was looking at this first slide, I said, boy, I really better look at that policy because I bet it's not up to date right now because we've made some tweaks to the process. And so ED staff needs to know, okay, what's the procedure for this thing? What do I do? What's my responsibility and that sort of thing? So that was all, you know, reduced to writing in the policy. And we brought that through staff meetings and through nursing ED leadership, because typically the nurses that are dealing mostly with this with the recovery coaches. So, you know, what's my responsibility? We brought that to leadership. They made some tweaks, and then we brought it to staff meeting to talk about how this was going to work. And which brings me to the final, my final piece of this slide would be staff education. And I can tell you that originally the staff education was, okay, here's the policy, here's what's going to work, here's how it's going to work. Daisy sent in one of her recovery coaches, which I think was impressive because, as Daisy, I've learned a lot through this, and as she taught me, the ED sees people for a snippet of time at their worst moment. And so their impression of somebody who's a recovery coach who's actually been in recovery is a lot different when someone comes and presents to them and they can see that person as a professional, which is not how they typically see them when they show up at the door. I think that went a long way. But we've done a lot since then, which I think has helped because some of the people were on the phone, so it kind of lost something in the translation, but that was our initial attempt on staff education for how this would work. And
yeah, we did like a short presentation, and the recovery coach was wearing a suit and tie and didn't identify himself as being in long-term recovery until the very end of the presentation, and you could hear this collective like, in the room, just because they were so impressed with him, and I think it really was the first moment of like stigma, flashing lights, right? They all had this idea of who he was, and then when he said, I'm in long-term recovery, they had to shift their perspective of what someone in long-term recovery looks like, because there he was. And it was not what they were picturing. And so for the navigating side of things, Marge was doing a lot of the legwork and the groundwork. We had to get the coaches through the HR process, and we'll talk about the challenges of that when we get to our challenges slide. But for us, it was pretty easy. We got a cell phone. We got the number, and we printed up like postcard size cards that had the 24/7 telephone number, because this is a 24/7 program. So in big red letters, it's, hospital staff only, here's our 24/7 number, call it any time a person presents to the emergency department having survived an overdose. And one of the changes we later made was other patients in the hospital. And then we had like our Monday through Friday 9 to 5 office number, so they could call us there too if they wanted to, during the day. And so we handed those out to all the emergency staff. We left them at the front desk so Marge could hand them out to other staff who might be wanting to use that number. We did it at Franklin and at Lakes, and that's kind of how we got started, and we just waited for the phone calls to come in. Okay.
Okay, so we talked a little bit about a champion, which I definitely think is helpful, and the fact that it's a person overseeing the whole clinical environment versus in the silo, and trying to break down the barriers. So you think about an emergency room, and emergency rooms have changed over time, right? A lot of what nurses and physicians see in emergency rooms now is behavioral health patients, whether they be mental health or overdose, substance use disorder, okay? Nurses and physicians didn't see themselves going into emergency medicine with that patient population. And so you had to make sure that, and over time this has changed, that yes, that's part of our population, and that's part of the people that you're going to see in emergency medicine now. It's not just going to be heart attacks. It's not just medical conditions. It's other conditions. And I remember we work closely with Corey Gately, who runs the recovery clinic for medication-assisted treatment. And I remember, and that's what I mean, like, I really got an education in this, because she would say to me, Marge, if somebody's a chronic diabetic and they come into an emergency room because they didn't follow the diet they were supposed to, why do people treat them any differently? This is a chronic condition that it's really the same thing. So that type of education had to go on when we were trying to build those relationships. I think we've already talked about, we talked about the coaches as professionals, but the other thing is, we wanted the ED staff to say, this isn't an extra thing we're asking you to do, like a task to check off, like, oh, now I got to call a recovery coach. You know, no, this is like a resource, because not only will the recovery coach help you with that particular patient, the recovery coach can help support you or the family, which helps your workload. So the recovery coach as a professional and as a resource to staff, not just as the particular patient resource. And so that took a little bit of time, but we're getting there on that people are seeing the recovery coach process as very different than those first few days. I don't know when you want to talk about stigma talks.
Yeah, so when Marge says that you need a champion at the senior level, she really was a champion for us, and she advocated for navigating. One of the first instances of stigma that we encountered was one of the recovery coaches getting his blood drawn for his drug screen, and he had track marks, and he had scars from that. And the nurse started to lay into him about you people. And so when he came back, very shooken up about that experience, because this is all supposed to be a positive and, experience at the hospital, he came back and told me about it, and I got very like, mama bear. And so I called Marge because I was getting ready to go up to the hospital and find this nurse and talk to her. And Marge says, I'll do it. And she did. She tracked down the nurse, and she had a chat with her. And it was great. It was in that moment where I was like, we really have somebody at the hospital whose voice is much more powerful than mine was going to be going to talk to that nurse. I might have also been a little bit more on the upset side than Marge presented as. And so she got that message across, like, this is not how we're treating these coaches. These are professionals. This is not the time to take that personal opinion of someone and express it to them in that moment. And this person is already in long-term recovery. Now is not the time to start, punishing him and just discriminating against him for his choices in the past or the disease that he was suffering from. This is the person who's going to be helping us with all of the patients who are suffering from substance use disorder moving forward. So it was really great because I was getting ready to just drive up to the hospital and have that chat, and Marge says, I've got it, taken care of. So, champion at senior level was fantastic. And so as time went on, this wasn't the only occurrence we had with a little bit of stigma from the hospital staff. So we started talking about how we were going to reduce the stigma, and education seemed like one of the easier ways. In addition to the coaches getting to know the hospital staff as they went in and really develop those one-on-one relationships, but at the same time doing hospital-wide education. So not just to the emergency department, but to all hospital staff who are willing to attend. So Corey Gately and I developed a stigma reduction training where we talked about the science of the disease, really explaining what it looks like. Some people have seen that presentation. And I felt at first like it was a little redundant because we were talking to medical professionals. Don't they know how the science of addiction works? How this is substance use disorder as a disease? Don't they know that? The answer was no. And I thought for sure we were going to be preaching to the choir about brain disease, but it turned out that they had tons of questions and they were learning a lot from us, which was eye-opening to me because I really felt like, oh, we're not even the doctors, and we're going in and we're talking to doctors, and we really did educate them on that. But we had to incentivize staff to come, and so we paid them for the 1-hour training, so they got paid to come to that. We fed them with money from another grant. Food is always an incentive, and they got CEUs. So those three things combined, we ended up having 250 staff members come to our training. We did it 25 at a time. So, we kept it a reasonable group, both at the Franklin campus and at Lakes. And then, now Corey goes in and does it as part of the HR onboarding process. So every new hire gets it as well from Corey. So that was the incentive to attend. We had security attend, we had nurses, doctors. Some of the security personnel actually have a lot of contact with these patients because, especially with meth being more prevalent, they end up in the annex and security has to guard them, and so they end up talking to these patients. And we had one security staff member who came to us afterwards and said that he was standing outside of a patient's room and started talking to the patient and was keeping in mind the stigma training that we had done. And so he just started talking to him like a person, he said. And they talked about making your bed every day. One little thing that you can do. Make your bed every day. That person ended up keeping in touch with him at the 30-day, the 60-day, the 90-day. He still writes letters to this security guard because he really said, thank you. You treated me like a human being. So that was one of our gems from training all of the hospital staff. Yeah.
We had one of the EMS guys, this is anecdotal, but one of the EMS guys, months after, or a couple months after the stigma talks, say that, I don't know what you did differently, I don't know what you changed, but it's a whole different environment when we bring a patient in now. And so, you know, we'll have to keep that sustainable, obviously, but that in and of itself was, you know, eye-opening, that there was recognition that something had been done to change the climate there, culture.
And I'll talk a little bit more about the emergency department staff seeing coaches as a resource and not just another to-do list. But the relationship that's developed now between the ED staff and the coaches, I mean, it's first name basis. It's when we pick up the on-call phone, oh, hey, yeah, you know, hi, Lauren, how's it going? And I ended up in the emergency department with a family member, and I was wearing my Navigating Recovery sweatshirt, and I actually don't ever go up to provide services. I just stay at the office doing work. And so when I was sitting there, the nurse said to me, you know, it was my mom and she was cold and she needed another warm blanket. And the nurse said, oh, well, you know where the warm blankets are, go and get one. And I said, I do? She goes, oh, you're wearing the Navigating sweatshirt, I just assumed. And I thought, wow, coaches, just wearing that, I didn't have a badge, there was no, she just saw my logo and assumed that I was one of the coaches that comes up to provide services and helped herself to a warm blanket. I thought, wow, okay, the coaches really have developed a relationship with the staff to the point that, like, I don't know, it was just really, it was a nice moment to have her just make that assumption and have it be a very positive one.
Yeah. The other thing on stigma talks is that recently we knew that some of the physicians had made comments that were less than attractive to each other in the department. And so we have two physicians that work in the recovery clinic, the medication-assisted treatment clinic, along with Corey, did intense stigma reduction with ED physicians recently, which seems to have changed over quite a bit because, you know, we could do everything with the nurses and we can do everything with security, but if you've got a couple of physicians that aren't playing, they can really change climate back. And so that, I think, was really important. And some of them have even gone for their X-waiver training because we do medication-assisted treatment now through the foundation grant, because not just recovery coaches, through the foundation grant, we do inductions in both our emergency departments. And so that was another stigma change.
Okay, now to our challenges. So I would say that one of the first challenges we faced that just was like, oh, hadn't even thought of that, was immunization records. So they had to provide, all the coaches had to provide their immunization records, but many of the coaches, you know, during their time of active use, they don't have access to their immunization records from when they were little. They couldn't just call up their PCP from when they were little and ask for those records, or their mom didn't have them, or things like that. So because that was a requirement, then we had to do titers. Yep. Can you explain what that is? I don't.
So titers is a blood draw to see if, rather than getting an immunization and knowing the person now is protected, you do a blood draw to see antibodies. So, and then you can decide that the person doesn't need to get the vaccine or the immunizations.
And titers is not a cheap or an inexpensive test. And so, again, it was fantastic because we were able to pay for the titers from the grant, which would have been an insurmountable expense for Navigating or the coach to pay for. So now, instead of having to have the immunization records, if someone didn't have access to those, we did the titers, and then we could see if they needed to have anything updated or not. So that was one of the first, like, oh, hadn't occurred to me that that was going to be a challenge. And then the background checks was another one where having our senior champion really came in handy. Do you want to, how you change that?
Yeah, so, and I'm going to have Daisy remind me how I changed that, but there was, I think it was remind me what it was.
So the first background check that we did, and we had it sent to the HR department, I got a phone call from the woman who was like, oh, they have felonies.
Oh, yeah.
And I said, or this, you know, she said, this particular person has felonies. And I said, they're all going to have felonies. And so we had to figure out which, there were the big ones that, were the non-starters. I wasn't going to send anybody up to the hospital to go through the HR process if they had any of those non-starters, like child abuse, elder abuse, sexual assault, or violent crimes, because those aren't things that we can send people out into the community to work with other community members for. But the other felonies, drug charges, those were things that weren't supposed to be insurmountable, especially because if you're getting your CRSW, you can write a letter, right? And those are kind of excused or accepted. So that's
so thank you. So yeah, I can remember that because, the people in HR that you're typically dealing with on screenings and hiring, they would go like, oh my gosh, well, that, if it were an employee, it would probably be, that would be it, and so I had to go to the senior VP for HR and, kind of do a reasoning behind it and that sort of thing, and it was kind of like, I got to get this going, and she basically said, yep, you're right, just do it. And so that was a definite improvement, and some, hospitals aren't great at tweaking the rules, and they did. And that, if we hadn't had that, we would have no program. So that was good.
And I should mention, we started off with all recovery coaches in process because we were a brand new RCO, and now they're all CRSWs. So moving forward, we'll only send CRSWs up to be part of the hospital on-call support program. But when we started, they were all recovery coaches, and so our MOU said that, accepted that and said that they were in process and would achieve these, the CRSW steps within time. So. Yeah. And then I think with the engaging staff and keeping them engaged, this is a part, going back to the stigma reduction training that Corey and I did, and continuing to do it on a regular basis. We had some ebbs and flows in the phone calls that we receive. When I said we put out the cell phone number and then waited for the phone to ring, I think we were all surprised that I think the first month we got 5 phone calls. And we knew, because we have both police and fire department on our board, that there were way more overdoses than 5 in that 1 month. And so we had to figure out, how do we get people to utilize us? And what we discovered was we'd educated the day shift. We hadn't gone in to educate the overnight shift, which was when most of the overdoses were coming in. So once we educated them, we went from 5 or 6 to like 17 and 18 a month, right? We started getting called on a much more regular basis. And so it's still, we have ebbs and flows depending on the shift, who's there, how personnel
changes. Staff, yeah.
Yeah, so we have to always stay on top of that. And when we see that the numbers are getting lower, but we know that overdoses are happening in the community, we say now's the time to go back in and educate the new staff.
And I'll just mention that we're using the foundation money to also change the assessment form in our EMR, because really, quite honestly, we don't just want people that have come in that have overdosed. We want the next level. Who's at risk of overdose? If we can get to that group of people, then we prevent the overdose. And so we've been working on that for way too long, but I think we finally got agreement on what that assessment will look like. So we hope to have that in the EMR within the next month, and that'll get to that, layer below that you're worried about, but they haven't done any overdose damage yet, I guess is the way I would put it. So.
Can I ask a question on that? How are you going to implement that? Like, if you're trying to prevent the people that might overdose, how are you reaching them when they overdose and come to the ER?
Yeah, so I don't have a great answer because we haven't done it yet, but here's what we hope will happen is that we have certain risk factors built into the assessment, and if you know anything about EMRs in hospitals, it's all about the number of clicks. Nobody wants like 9 and 10 clicks, they want like 2. So we have very streamlined questions that the nurse on the nursing assessment will check off, and then that'll send a referral to either a social worker or to Corey, and then they'll go in and basically interview the patient and ask more questions. And it has to do, like, it's not going to just be for opioid. I mean, we've got alcohol in there, based on how many, and certainly you need somebody to be truthful. I drink more than 4 drinks a day or whatever it is. So it's standardized, just a couple of standardized questions. I think we put something about substance misuse and we have them checking off. There's a list of substances that the nurse can check off, amphetamines, opioid, that sort of thing. So
how is the assessment getting to the person? Are you waiting for them to come into the ED, or is it another sort of outreach?
Yeah, for right now, you're absolutely right. We're waiting, in this particular grant from the foundation, we're waiting for them to come into the ED.
But people present to the ED for far more medical reasons than just an overdose.
Yeah, and actually, now that you say that, this assessment is in our EMR, so it's global. So the practices will be able to do the same thing. So in the provider practices, they'll be able to fill it out. But I think where the integration of that, we won't get into this, but when we start the doorway, when we really get up and running, we've only been up and running like 3 weeks, but the newest opioid hub and spoke grant from the state, I think we will reach more people than just those that show up either at a PCP office, which many people do not, and emergency rooms. So,
Would you be willing to share your template for the assessment?
Sure.
And do you know, like for the hub and spoke, they do an assessment as well?
Yeah, the hub and spoke, our hub and spoke is going to be that there's a recovery coach is going to be the first contact. And then
we have a LADAC there as well.
Yeah, LADAC there to do an evaluation, and so that's how that'll work. They won't really be doing the assessment in the EMR, but probably we should
for anyone who ends up, because people who walk into the doorway aren't technically hospital patients yet. Depending on the level of care that's needed, they might become a hospital patient.
Yeah, the people that I've referred to the hub and team, they do that over the phone assessment.
So we will do that through our clinician. They'll be on site actually during the hub hours, which are 8 to 5. Oh.
This assessment is different than the full-blown assessment.
Yeah.
This assessment is very brief, and it's just to assess somebody's risk for having a substance use disorder. And it's for somebody who's with a broken arm, around the steps, or whatever other reason somebody came to the emergency department to assess out whether or not they might be at risk for substance use disorder. And it's just quickly to say, okay, let's do a brief intervention to set expert, and then refer somebody to treatment.
Yeah. Rebecca, do you want to introduce yourself?
Sure. I'm Rebecca Skye. I work here at the Foundation for Health Communities, and the Foundation for Health Communities received a grant from the Bureau of Drug and Alcohol Services, so we were able to get out to the hospitals to do the emergency department project. So I think I'm looking in here and understand from the point of view of a recovery organization working in this field.
Are you doing across the state?
So that it's just a small number of hospitals, worked with 7 hospitals, and each has taken a different approach. So there are 3 hospitals that are using recovery coaches in their departments. But all of them are working to transform care for patients with substance use.
Okay. And so then one other lesson that we learned was that we switched from having the nurse ask for permission to have a recovery coach come in, because a lot of times people said no, not really understanding what that meant or who it was going to be. And so we made the switch that we just weren't going to ask permission. They were just going to call us and we're going to show up, because even if the patient doesn't want to see the recovery coach when they walk in that room, there might be family members who want to talk to them. And we kept encouraging the emergency department staff, or you can talk to them. If you have questions and you've called them up to see somebody and that person doesn't want to see them, ask your questions, learn more, really use them as a resource in that moment. And so that was part of why we made that change. And so now one of our other anecdotes, and I guess I'll skip ahead to the measuring successes slide, is that when we made this change and family members who were standing in the hallway or wondering what they were going to do started talking to recovery coaches, we provide family support services at Navigating Recovery. So we've had several family members who talk to a recovery coach while their loved one was in the hospital, come and get one-on-one support services, come to our family workshops. We had one family where the mom was the patient that we were called up to see. She was not in any condition to talk to the recovery coach when they got there, but the father was standing in the hallway with their 3 children. And so the father started talking to the recovery coach, and next thing you know, all 3 kids have come to Navigating. They were all over 12, for different group support meetings. The father was coming to Smart Recovery for family and friends. He then brought his wife. We got her into treatment. So it started more with the family in the hallway than it did with a patient who couldn't talk to us at the time. Because one of the, going back to the challenges, was that even though we asked hospital staff to wait until the patient was alert and conscious to talk to us, that's not always the case. Oftentimes when we get there within 30 minutes, the patient still isn't in a place to communicate. And if we can't talk to them, we can't really coach them or help them. So that is one of the challenges we're still working on, is really asking the hospital staff to wait until that person is awake because we can't do any help when we can't actually talk to them. So. And then, so other ways of measuring success, how many patients present to the emergency department with substance use disorder compared to how many times we're actually called. We know we're not always called when a patient is there with substance use disorder, so we're working on trying to compare those numbers and then figure out how we can make that, you know, more of a match. Did you want to talk more about that, or is that okay? And then how many patients actually show up at Navigating Recovery after we've seen them at the hospital? So we have seen 266 patients since we started this program in May of 2017, and that's at both campuses. I didn't tease apart Lakes and Franklin. So 266 total. 80 of them were homeless and don't have contact information. So even though we saw them in the hospital and we encouraged them to come to Navigating, if they don't, we have no way to follow up with them. We don't have an address. We don't have a telephone number. So we lose them in that. 79 of them we linked with substance use treatment, so either detox, inpatient, medication-assisted treatment that we can do right in the emergency department, or intensive outpatient programming. 5 of them we linked with housing. 8 we made mental health service referrals for co-occurring disorders. And 43 of them received coaching at Navigating Recovery. So 43 out of the 266 still come to Navigating for their coaching. So that isn't, you know, it's about 16%. It's not a great percentage. We want to see that increase. And then the other 51, this is where the challenging part comes in. We call and leave a voicemail. They don't call back. Our telephone number is restricted at Navigating. People don't pick up restricted numbers. I don't pick up restricted numbers. I wait for them to leave a voicemail, and then I call them back. So out of the 51, their voicemail box is full. Their voicemail isn't set up. They just don't return our calls. Or they make an appointment and never show up. Some of them have been arrested. So that's kind of, you know, we've got this 51 that's the other category. And actually on the way down here, I just realized, talking to Marge about this, the ones that have been arrested, we actually, chances are, we'll end up seeing them in Belknap County Corrections, where we go in and do recovery coaching. So if I'd actually taken the time, I could have found out how many of those that are arrested are having our services provided to them. And then part of their probation is that they have to keep coming to Navigating, so chances are we'll keep working with that person. So because we lost them from the hospital support program doesn't mean we lost touch with them altogether. And then anyone who refuses to see us when we go up there, we don't have it captured because we don't get any contact information about them. And if they didn't have family members that wanted to talk to us, we don't have any info on them. So they're not part of the 266. If someone refuses to talk to us, we don't capture that at all. Yeah, and our program is still evolving, so it's great to have, you know, senior leadership who's willing to work with us if we want to change things. Like the MAT wasn't originally part of the program. We added MAT induction as we went along. Yeah, so it's been a good ride so far. Anything else you want to add, Marge?
No, I'm good.
Okay. I think that is all we have.
Can I have
Mindy?
a quick question, Daisy? The 79 linked with substance use treatment and 43 receiving recovery coaching, are those discrete numbers, or are some of those getting both?
Some of those are getting both. Yeah. Yeah.
Thank you both so
You're
much.
welcome. Thank you.
Good job.
All right, so here's our mission statement, which I won't read to you, but for us, our initial steps when we started this kind of came out of, we had a community access to recovery program, as we call it, which was with local Somersworth and Dover police departments, where anybody who walked into any of the police departments or fire departments in Dover, they could access a recovery coach. And the way that program, we set it up, was they would go to the police department or the fire station. If they wanted help they would dispatch a coach from SOS, and we had made an arrangement with Wentworth Douglas to have them not admitted but put in a side conference room in the AED, and our coaches would meet them there. And that actually launched before we ever opened a recovery center. So that was when we were still planning our Rochester and Dover recovery centers. We started that program. And so kind of through that was how we identified this need for, well, why do they need to go to the police department? That doesn't make sense. And how could we make this work with the emergency department and with Wentworth Douglas? So somewhere around the spring 2016, we kind of identified this need, and myself and Kelly started collaborating on, okay, what does it look like, and how do we start this process, having no clue how we were going to get from A to Z. We just, Kelly really championed it from there, and that was kind of the starting point for us. So we we ended up putting together a formal proposal for the hospital in May of 2017. And one of the things we identified in that proposal, as me and Kelly talked through this and we kind of brainstormed, was we originally intended this to be for the emergency department, but we were kind of talking, we're like, well, why does it just need to be the emergency department? Let's just make it hospital-wide. Like, there's people in inpatient that could use our services too. So that was how we structured the contract, was that it could be throughout the hospital. It wouldn't just be an emergency department coaching. So Kelly really ran with it from there. So I'll let her kind of talk through a lot of that stuff. A lot of it was really getting it through compliance in the hospital and a lot of the same challenges that they faced with. I will say that one big difference we had is SOS is a program of Goodwin Community Health, which is a federally qualified health center. So a lot of the vetting for employees involved, we already do the TB test and a lot of the immunization stuff, so that made it a little bit easier. There was still additional hoops, but I'll let you kind of.
So from the hospital perspective, as John said, we already had the community access to recovery program, but our own team in the hospital would say it wasn't really utilized. So surprisingly, community members weren't walking into a police department saying, I need help. They were walking into our emergency room. And so we kept saying, this doesn't make sense. They have access to a coach if they walk into the police department, but they don't have access to a coach if they walk into the emergency department. So that was what started some of the conversation. And as I said, we've been building behavioral health teams, and I have a behavioral health steering committee at the hospital, and one of the months around the same time, our CEO, who's part of that meeting, walked in and handed me an article and said, Kelly, you have to read this. There's this thing called recovery coaches, and it sounds amazing. And I said, it is amazing, and we have it already right in our community. And he said, well, we need that. And I said, okay, then let's do it. And so certainly, although I was the champion, it was always helpful for me to say, well, and our CEO wants this. So, anytime you can slip that in, that helps. And so it was really helpful that some of the other senior leaders at the organization, even if they didn't understand all the nuances of it, conceptually said this is important. So John and I, John did a great job of putting together a proposal for how we were going to do this. Seemed straightforward. We were going to sign a contract. We called them professional affiliate agreements. And I would say ditto, really, to everything you heard from Marge. Nothing is that straightforward at a hospital. We love policies. We love compliance. We love HR regulations. We're Joint Commission accredited, so we love meeting all their requirements. And it soon became apparent that it was going to take us quite some time to put together what the contract was going to look like so that it met both SOS's needs and the hospital's needs. And so that took a lot longer than we expected. A lot of meetings with HR. Wentworth Douglas had just been acquired by Mass General, so it then involved another layer of conversations with Mass General and with partners, and so everything just became more complicated on our end. And then, although I felt very confident that we had the CEO's backing, there still was that pesky question of, so how are we going to pay for this? And our hospital has its own foundation that raises money for programs within our organization. And so I approached them, and John and I completely made up numbers for what we thought this was going to cost per year because we had no idea. We didn't really know how to expect, we didn't know how to anticipate volume. So we just kind of picked some numbers out and put together a proposal, and the foundation awarded us, I think it was an $8,000 grant to get this started. And unfortunately, the grant had a lifespan, and we ate up some of that time figuring out all of this back and forth around the HR, all of the things that Marge and Daisy talked about in terms of all the HR requirements were the exact same things we were trying to work out. So we finally got past all of that, but it was literally months on our end of meetings and back and forth with the contract. And so then we said, okay, we were ready to flip that switch and get started.
Yeah, and one of the other things that we ran into too is when we envisioned this, our plan was, SOS, I think at that time we had 20, 25 volunteer recovery coaches. So for us, you don't have to be a CRSW. Our requirement for our coaches is that they have to have completed the Recovery Coach Academy in Ethics, which is the same requirement that we have for our volunteers. So when we envisioned this, our plan was we'll have volunteers do this. And then it turned out with workers' comp and liability issues with the hospital, Kelly's like, that's not going to work, John. They have to be employees. So that really limited our capacity coming out of the gates because everybody, you don't have to be a CRSW, but you do have to be staff with SOS. So in order to do this, that certainly threw a monkey wrench into things. Luckily, we've expanded enough and we have enough staff that we can kind of jump through the hoops with this, but that was kind of an unexpected thing. And then the vetting was still a little bit, there's still some stuff like Goodwin doesn't do checks with the Bureau of Elderly and Adult Services. So we have to send that off. We already do the federal background check, so that wasn't a big deal. But drug tests. So like one of the challenges I still have today is Goodwin does not have a policy with pre-employment drug testing, and that's very intentional that they don't want that policy. But in order to be a coach at Wentworth Douglas, you do have to pass a pre-employment drug test. So one of the challenges is we're now 24/7, so I have coaches that are strictly per diems, and they are dispatched for this program and our law enforcement assisted diversion program. So I can't put in our hiring that you have to pass a pre-employment drug test. And I went to HR and I'm like, so what if I hire somebody, I can't put it in the expectations, and then I hire them, and what if they don't pass the drug test? And they're like, well, you can't fire them for that. And I'm like, but I can't use them. So fortunately, we haven't had that happen, but that's one of those things that's kind of sitting there that is challenging with something like this that you kind of have to think through, because Goodwin's not going to change that pre-employment. If they do it for one person, they have to do it for everybody legally. So it's kind of there's a discrepancy there. I'm like, I guess I have a per diem that I can never schedule if that happens.
And like you, we also said that since that's not something you're requiring, that we would pay for that. So we were taking the drug test. They send the invoice to us through the ReadyCare for that.
Right. And I think the other thing is we don't require physicals, so all of our employees have to go dig up physicals or go get one. And in the cases where they haven't had one, I think we have absorbed that cost, and we'll send them to Convene MD or one of the local urgent cares to get a quick physical just to clear them. And it's just they have to send in a letter saying that they're cleared to perform the duties of their job. So we started the implementation. We ended up launching in April of 2018. And what we did is in our proposal, we did it in 3 phases. We said we'd do a 9 to 5 Monday through Saturday, and then we'd go to a second shift till I think it was going to be phase 2 would be a second shift starting 6 months after the first one, and then pilot that, and then we'd go to 24/7. We ended up going through to November in phase 1, and we skipped phase 2 and went straight. It was working really well. We were really kind of in a good way, worlds collided. We already had the law enforcement assisted diversion program, which was a program where we do pre-arrest diversions in Dover and Farmington, and we have to have part of that is the police departments want warm handoffs within an hour. So I have to have people on call overnight, 24 hours a day, 7 days a week anyways. The integrated delivery network identified that as part of kind of what they wanted, so they've helped provide some of the funding for that whole per diem piece. So we've already got some scale where we're getting, I think we have 3 different grants basically funding. We have the foundation funding the coaching, which is more of a fee for service as we view it as an RCO. We have the IDN helping a little bit, and then we have a grant from Open Societies Foundation for the LEAD program, and we're able to use the coaches that do LEAD for the hospital as well. So they could be dispatched to either of those programs 24 hours a day, 7 days a week. So in November, we ended up shifting straight from the daytime hours to a 24/7. So that just started. That was November 15th. And then some of the stuff we did early on for implementation is basically me going in, doing a lot of outreach with staff meetings. So I think we did 2 for the ED, right? And then we did 2 for like social workers and nursing in the hospital, so that we could hit multiple shifts. And that was just kind of introducing the program. When we did the 9 to 5 behavioral health and social work were the 2 that we limited it to those dispatching. It's now gone, now that we're 24/7. It's any provider, right? Anybody, any nurse, any social worker, or behavioral health, anybody can dispatch us now. So one of the big things that, what we didn't expect is we designed this originally as an emergency department program. And what we found, though, is we got very little engagement from the emergency department. We got a ton of engagement from the inpatient unit. So all the inpatient floors, we were getting, we averaged probably like 8 to 9 dispatches a month. And I think in the first 6 months, we had like 2 calls from the emergency department total. So it was almost always to a lot of alcohol related, a lot of demographics that we're not typically seeing at the recovery centers too. So I would say 65–70% were alcohol related and not opioids. So that was unexpected. The social work department really kind of identified that this was working for them, and so we just had a lot of engagement from social work in the inpatient units, which we never saw that. Likewise, we didn't see that we would have a lack of engagement from the ED. And
so we needed to drill down on that a little bit and try to figure out. We had some theories about why that was happening, and I think that what happened was we had a couple, as John said, a couple of social workers early on called on the inpatient floors, and some of those early calls went really well. And that social worker became a champion. So once they had an experience that they saw as really being beneficial, then that was something they were going to continue to utilize. On the inpatient floors, you also have a lot longer to be working with the patient. Emergency departments are very fast-paced, and exactly as Marge was saying, you didn't want this to seem like one more thing they had to add to something they had to do in the emergency department. And I think that's really was the perception at first. When we tried to follow up with social work, let's say in the emergency department, and say, why isn't this being used? You guys were asking for this. It's a great service. You believe in it. She said, well, the patients are just in and out too quickly. So one of the things that was happening was just, as you've already heard, was a nurse or a doctor would say, do you want to meet with a recovery coach? And one was probably how it was being asked. Right. The second was when it was being asked. Here are your discharge instructions. You're all set to go. Would you like to meet with a recovery coach? No, I'd like to leave. So the timing of when you were asking, and the fact that it was a nurse or a doctor asking. So we also are trying to shift to, even when I worked in the social work department, if the nurse asked a patient on the floor, do you want to meet with a social worker? Absolutely not. But if I walked in, introduced myself, started a conversation, and then through that explained who I was and why I was there, 15 years, I can't think of maybe one or two times where I ended up being asked to leave by the patient. So we really started educating the ED around, let's call the coach, call them early, so we understand the patient might not be ready yet, but we'd rather the coach be there so when the patient's ready to talk, the coach can go in and introduce themselves. And then you're less likely to have the patient, decline the visit. So call them early, and then that way they're not waiting. So we knew if you're going to ask, as long as the waits are, if you wait till right before discharge, they're not going to want to wait any longer. Our contract also says 60 minutes, so plenty of time. But I think those 2 changes alone will make a difference in terms of, call and let the coach offer their services, and call early in the patient's stay in the emergency department.
Yeah,
I have a question about what you were talking about before around, dispatching. Who's making the call? Are the staff in the ED making the call to you and then you're calling your coaches, or are they calling the coaches?
So what we ended up doing with this program and the LEAD program is we have, so Ashley and Denny tend to be the primary ones during the daytime, and they have company-issued phones now, and then we actually paid for a dispatching service. So we have an 800 number that we use for the hospital and the police departments. That's a private 800 number only for the dispatch service.
So the staff in the hospital calls this 800 number?
So the staff calls the 800 number, and the dispatch service calls whoever. I send them a schedule every week, 2 weeks, and saying, like, here's who's on call 24/7, and it kind of I usually have, like, a primary and then 2 backups with instructions, like, if you call our primary on call and don't receive an answer in 10 minutes, call the backup, and if that doesn't work in 10 minutes and you don't hear back, call the second backup. So I literally have this pretty complicated pain in the butt schedule.
Have you ever considered using like a Google Calendar where people can put themselves into a slot, a schedule or a shift that's accessible by the hospital staff, where they can see exactly who, and then maybe cut out that?
I think it's
You want to make things as simple as possible for the hospital staff, so you need one phone number, one phone call, to be honest, they're not going to go to NAP, they're not going to look at the calendar, they're not going to do any of that.
9 to 5, we had a different phone line, and we switched it to this 800 number, so we're still getting some calls to that old line. And we also have the occasional social worker who just calls SOS in Dover and says, like, hey, I need somebody. And they're like, why are they calling SOS? I don't know. Like, give her the 800 number, and next time, hopefully, she'll call the 800 number. So, yeah, you have to keep it really simple, because otherwise it'll go off the rails pretty quickly, I think, if you did something like that.
Realistically.
2 more questions, if that's okay. Do you also include resources in your discharge paperwork?
For SOS, if the patient refuses, they offer, to give them those resources. It's not, it's something they'd have to add to the discharge paperwork in terms of the phone numbers and so forth, or give them a brochure.
Okay, and then your professional affiliation agreement and contract, is that anything, a template that you'd be willing to share?
It's just I don't know that you'd find it helpful. I mean, I can send it. It's not, every organization has a policy around how you write contracts. So it's like an MOU. It's like we just call it a professional service. So our MOUs that are for services we bring into patients, we call professional service agreements. I mean, I can send you to see what it looks like. They're fairly straightforward.
Exciting read.
It has, I mean, you'd want to go through it depends on your legal team. So you'd want to go through your organization's legal team to find out what kind of legal verbiage you would have to include. Our legal team gives us different answers than other organizations. We've learned this through the doorway, whereas the state's trying to get us to all operate, the same, but our legal team wants an MOU to read one way and another legal team wants it to read a completely different way. So I'd really encourage you, if you have access to a compliance or legal team or somebody who oversees your organization, they're going to pick apart and have it follow what their guidelines are. But I'm happy to forward what our contract is, essentially.
And so some of the recent changes, and we alluded to that, so we ended up, because we weren't getting any AD calls, we just had a brainstorming session. That was actually held January 4th. So just after the new year, we kind of said, okay, how do we get the ED? So we met with the emergency department nursing manager, the case managers in the ED, the director of the physicians in the ED, and the social workers that work in the ED. So all of us kind of had a meeting this month, at the beginning of the month, and said, what can we do? So some of the changes we made are, and some of these policies haven't even been implemented, I don't think, yet. Like, if there's an overdose, they're automatically going to call us. If somebody's presenting inactive withdrawals, they will automatically call us. We actually, one of the things that I'll be interested as this moves forward that we've talked about is individuals who come in who might only be seeking SUD-related services but don't have any other medical condition. There's really no need to register them and triage them. They're looking at, let's put them in the conference rooms like we used to and rather than go through that whole registration process, just call a coach And if the coach comes in and we recognize like, hey, this person needs medical care, we can grab a nurse. So we identified that we think that's probably going to be really helpful because there are some with compassion fatigue, and like what better way to get doctors and providers engaged than they've got backup of 8 patients and they can put somebody over in a conference room and let us handle the SUD piece of it and navigating that. And if they don't need that triage team, and let's face it, somebody who's going in there is probably looking for like comfort meds or detox. They don't really want to be triaged either, so it'll kind of be a win-win for everybody. I mean, I think any of us who have ever gone to an ED, we when it's related to addiction and SUD, like, it's kind of the last place on earth we want to go.
And with the doorway opening now, we're not located within the hospital, so our doorway is located across the street from the hospital. And so the idea is exactly that, to not have the patient necessarily be in the emergency department, and that might be where they present saying they want resources. And then the ED staff now are saying, what do we call a coach? Do we call a doorway? Do we call, and our mantra is going to be call a coach, call a coach, call a coach. Because the coach is going to help us ensure that we get the patient to the doorway. So, and we've had that happen where a coach came to the emergency department, met with the patient, and together they walked across the street and presented at the doorway. And that was a really great way of kind of closing that loop with the patient. But again, the idea is to keep a patient who doesn't medically need to be in the emergency department out of the emergency department.
I mean, we've recognized that doorways shut pretty quickly for individuals, and so they might come into the ED and then they say go across the street and they'll never be seen again. So if we get the coach in there, we can actually like stand along with them and prepare them like for that JIPRA assessment and some of those things, and kind of say like, this is the process when we get over there, and it's just across the street, and walk over there with them. So we'll see how that all plays out. But one thing that has, and since we had that meeting, we've had 12 calls in 14 days. I think it's 13 now and 16 or something. But I think that Friday we left at 10 in the morning. We got 3 calls that afternoon. Ashley, I think, went there, spent about 6 hours there. She kept trying to leave to go to the recovery center. She's like, I got to go back. I'm like, I'd call her. I'm like, you done? Yep, I'm headed to the center. Like, nope, turn around. So that's really helped. We've had a lot of engagement this month, and it's been like nonstop, almost on a daily basis where they're calling us. So that's been great.
And it speaks to that education piece, and that was just a handful of people that we met with. John and I were actually both at the Behavioral Health Conference and sat in the training that Daisy and Corey gave, and had a kind of an interesting initial reaction, exactly what you just talked about. So the training, you choose modules at the conference, and we chose this one and sat in, and John and I weren't sitting together, but we had a conversation after, and we had the same feeling, thinking like, oh, I wished I'd chosen a different module because, like, I know all this. This is so simple. I don't understand why we're presenting this at a behavioral health conference. And then the longer you sat there and you looked around at the look on people's faces in the room, you thought, oh, people don't get this. And you forget, you think that all your colleagues sitting in this room at a behavioral health conference would look at this information and think it's so basic. And it really was this huge aha moment for me that we started our program on step 3 and forgot to do steps 1 and 2. We forgot to provide that basic education because we're making assumptions that our colleagues have the same passion and knowledge that we do. They don't, just as you've heard. And so they don't. And Corey very nicely just yesterday forwarded me the slides because they were fantastic. That you guys did a really great job of being able to present information that was very digestible and really relatable and helps to reduce stigma. So now, just as we saw educating these, 5 people made a big difference, we need to go back and re-educate larger groups of people. It's very impressive, the number of people you've had go through the training. I would hope we could see numbers like that to be able to sustain this.
Incentive. Or require it.
But yeah.
We had a certain population of ED nurses where the ED director required it. They had to do it.
That helped.
But certainly, attending their presentation, we didn't do that basic, brain disease education of the providers, and me and Kelly just we started on step 3 or 4.
But to Kelly's point, so we made it mandatory for certain people, and people hate mandatory in-services, right? Like, oh, seriously? But by the time they left, they were really glad they went, and it allowed them time to ask questions and stuff, so it was helpful.
And then how are we measuring success? So one of the primary things we do is what's called a coaching satisfaction survey that the patients and participants take at the end of our coaching session. So we all bring in tablets there, and if they're not able to use a tablet, we have paper forms as well that they can do it on. So that it's basically 4 questions, which have since expanded, but I don't even remember what the questions are. Kind of like, did you feel like the coach met your needs? Did the coach connect you to treatment navigation?
It treated you with respect, were you, treated kindly, warmly, so it was, some about the outcome, but mostly really about how they were treated during that encounter, because we knew, the coaches can't always affect the outcome in that there might not always be the right resource for that person, but if they treated them kindly and warmly and showed them respect, that was going to help connect them hopefully to the recovery center where they could continue working on getting the resources they needed. So hospitals love quality metrics, and it's been really great to be able to say, well, we've done this many coaching encounters, but that doesn't really tell the whole story. We have a, greater than 90% always, answer on the satisfaction. So it's that being able to show that kind of not only the quantity of what's happening, but the quality of what's happening has helped me to be able to sort of sell and continue to sell this as a worthwhile program for the hospital.
And we built that into a SurveyMonkey so that the patient can do it without the coach actually knowing what their answers are. They just go through the questions if they're able to, which they aren't always. So since that first 4 questions, we've added 10. So I took from the recovery data platform, that has now expanded to 14 questions. So I used the 10-question engagement scale at the end of those, because one of our contractual requirements is to follow up within 48 hours with everybody that we see at the hospital. And our longer-term goal is to stay connected. So one of the things, and we don't know how this is going to work out. I think I threw in the engagement scale in November or October. But I want to kind of see if we can get that engagement scale and with follow-ups either through telephone recovery or recovery coaching or in the center, and putting all of the Wentworth Douglas Hospital individuals on that intake 30, 90, 6-month kind of schedule of contacting them and going through that engagement scale to see how their quality of life has improved, how their recovery capital has improved, and kind of those qualitative measures that you get with the engagement scale. I have no idea if it's going to work or not, but we've been able to get the engagement scales at all of them, so at least we're getting that starting point. And we also always do a recovery coaching log in the recovery data platform system when we go do these calls. So we monitor that. The majority, I would say 75% of the individuals we coach are willing and agree to sign up for telephone recovery supports. So we've had really good success with ongoing, way better than I expected. So I think, so we have over 50% of all the individuals we've coached have remained engaged with SOS in the last 90 days. So, I was looking through the telephone recovery supports, and I think like 25% of them are still active, and we've had an average of like 10 or 12 contacts with individuals that we've started that process of telephone recovery supports. So it's not, not everyone's a success story. We've had a few individuals that we've coached multiple times that, we've been dispatched 2 or 3 times for some individuals, but it's rare, and most of the people have stayed engaged at some level. And several of them have maintained recovery. I mean, there's a couple of people we call that have been abstinent since the day and identify as in recovery since the day we went in and coached them. So we've gotten some people into some residential treatment. We've connected some people to medically assisted. I mean, I can tell a brief anecdotal story. We just had one. This was 2 or 3 weeks ago. We had a female who was presented in the emergency room who was struggling. She was 18 years old. Her dad's girlfriend had brought her in. Both dad and the dad's girlfriend, they're all in active addiction, living in the same house. And I was dispatched, and I went in, and she was like, I don't have any interest. And I was like, that's fine. And I said, what about clean supplies and harm reduction? And she said, yeah. So we connected her actually with the local syringe service program. They actually did a house call to get them clean supplies. And then one of the things I identified is it's an 18-year-old female. So I said, Ashley, why don't you follow up with this person rather than me? There might be a better connection. She ended up not getting discharged, and she got put into inpatient, and there was a follow-up call like a day or two later, and I sent Ashley for that one, and I think she told Ashley some choice words when Ashley walked in. I was like, I'm not talking to you. Ashley was like, okay, and Ashley just kind of sat there. And since that time, she's been the same individual is now got some interest, and she met you at the recovery center, right?
Yeah, it was actually, this is like my favorite story since I've been dispatched to the hospital. I walked in and she was sleeping because she was just giving methadone for like some comfort meds because she was kicking heroin. And so I walk in and she's sleeping, and she had a 24-hour watch on her because I guess there was some drugs found on her in the emergency department. So the nurse is sitting there and she was sleeping, and I, as someone in recovery, know that it's really not. It's important to not disturb someone who's detoxing and comfortably sleeping. So I let her sleep. And so I sat there and I was like, if she doesn't wake up, I'll give her like a half, I'll sit here for a little while. And so she ended up waking up, and she rolled over and she was like, I don't know what the F she's doing here. And I was like, oh boy. And so I guess from what I was gathering is like the word treatment was just like shot her way, and it just became this huge shield. And so I was just kind of letting her vent and like swear and like go off, and the nurse had actually walked out and kind of let me just have some conversation with her. And so I just got real with her and just shared a little bit of my experience, and it changed like instantly. I ended up leaving with having texted my number into her phone, and she stored my number, and I thought that's a huge step compared to like what I just walked into. And I was like, I don't know if she'll follow through. And she told me she was going to get in touch with me to meet me at the center. This was a Friday, meet me at the center on Monday. First thing in the morning, she texts me and says, are we still on for today? And I was like, no way. I called John. I was like, you're never going to believe it. He was like, what? And I tell him, he's like, are you kidding me? I'm like, no. So I get her at the center, and she was definitely under the influence. She ended up vomiting at the center and stuff. But what was important, when I was at the hospital, the behavioral health worker had come in, and she had worked at Great Bay Mental Health, and this individual has some mental health situations. She was very vocal and told us all of this, and she had a really bad experience there, and she was not willing to go back, but she was willing to go back if she was seen by that specific person. And so me and the behavioral health individual were talking, and she's like, yes, if she does that, I'll see her. And I'm like, all right. So we get down to the center, and we actually call Great Bay Mental Health together. And we didn't get through to that exact nurse, but we left a message for her to call back. And so we had got her reacquainted with the center. She went back home, and I said, if you get a call back from Great Bay Mental Health, let me know, and we'll get you to that appointment. She called me 20 minutes later. She had already booked an appointment for Great Bay Mental Health, and she said, can you help me get there? And I was like, I'll make sure it happens. And I unfortunately at that time had a lead meeting, which is the law enforcement assistant version. I could not miss that. So I'm like, oh my God. I'm like, this is crazy. So I'm like telling John, I'm like, we got the appointment. I'm like, I have to get her there. So I call her as soon as the meeting's over, and she was at the mental health appointment. It was like just such an awesome experience because I had walked in, John had done some engagement with her, just wanted me to connect with her. She was so resistant, and now here we are only like 4 days later at a mental health appointment with that provider. It was like such an awesome experience.
Yeah.
Yeah.
So we've had a lot of those really good, those types of like, like holy. You just don't expect the results, the outcomes that you get. We try not to get tied to those outcomes because they're not all going to be perfect, but it's been a really positive experience, and the engagement that we're seeing with a lot of these individuals showing up at the recovery centers after the fact, or at least staying engaged with telephone recovery, are way higher than I would have expected. So,
I have a question about, do either of the hospitals offer a MAP component with this, and do the two of them coincide, like for follow-up?
Yeah.
Can you tell me about it?
Well, so we have MAT induction in the emergency department.
Yeah.
So when the recovery coach is talking to the patient, if that's a pathway that they want to choose, they can get linked with it right then and there. And then they are guaranteed an appointment at the recovery clinic the next day, unless there's the weekend and there's that one gap on a Sunday, Saturday to Sunday. So they can be seen on Monday at the recovery clinic to meet with a physician and actually start the MAT program.
They don't need an appointment, they can just walk in. If they're the only clients that can just walk in, everybody else needs appointments in the recovery clinic. But if they've been inducted in the ER, they can just show up.
And we don't currently offer, but we are talking about it.
That's all we have, but thank you.
We have about 5 minutes. I don't know if there's any initial questions. We can have questions at the end, but there is like a little buffer if people have any other questions for our presenters before we break up into small groups.
I just want to say what great success you've had, really, and particularly champions seems so critical at the hospitals to be connected with. What's the spread of this around the state? How many champions do we have in hospitals like you two that work with recovery coaches?
We're currently working on cloning Marge, so that
Yeah, I think the Doorway Project at the state, it's 9 hubs.
Yeah.
So I do think this will grow. One of the things that we're so thankful for is that, as we've said, there's a lot of bumps in the road, like, oh, I didn't think about that, or that sort of thing. And we were able to get those bumps out with the Foundation for Healthy Community grant, so that a lot of the stuff with the hub now, and the Doorway program is going to be a lot easier because we've been there already. And I imagine it'll be the same for you guys. You've already started stuff. But I think that's how it'll spread in the state, is that it's a much larger initiative now.
And how many recovery coaches do you have?
Well, SOS has 8 full-time employees and 2 part-time. I think 7 of them are specifically vetted for the hospital, and then we also have 4 per diems that do the on-call. We pay them a stipend, and then they get paid an hourly wage if we dispatch them.
We have to address the other hospital. I want to ask Rebecca to weigh in on this too from the foundation, but the Bureau of Drug and Alcohol Services has provided funding both to develop service support services. So both Navigating and SOS are funded through the Harbor Homes Facilitating Organization, and then Hope for New Hampshire and Riverbend have separate contracts for those services. At the same time, we contracted with the Foundation for Healthy Communities to help develop services both for medication-assisted treatment and then separately for emergency departments. So they work through the hospital system. In some cases, there's a match, like Navigating and LRGH. In other cases, there may not be, but one or the other of these 2 sides of the program may be actually funded to develop these services, and that's where some of this additional help for some of the bumps in the road. Rebecca, can you speak to where?
I was going to say, that financial piece is a realistic burden. You can have a champion, we can talk as loud as we can. Like I said, we were able to get our internal foundation grant. That was really helpful, but it had an endpoint. There was a little miscommunication within our team, and that endpoint ended up being 3 months earlier than I thought it was. So just as we went 24/7, and I thought, well, I've got 3 months to figure out how we're going to pay for it. That's plenty of time. I found out I had 2 weeks, and so had to go to our CFO and say, we can't stop this program. It's been fantastic, and I don't have a foundation grant for it anymore, so we just have to do this out of budget and figure it out. And so he agreed. He said, well, go ahead, do it out of budget. You've got 6 months to prove to us that this is really working, and then we'll just build it into next year's budget if that's the case. But he could have easily said, no, no, we don't have any more money. So knowing what that funding source is going to be is important.
Yeah. And the way we set up our contract, I don't think, we're not charging enough. Wentworth Douglas has helped a lot with funding of our Dover Recovery Center too, so, I'm not, what we're charging probably wouldn't cover, especially the overnight per diem piece. We've just been able to couple it together with this IDN money and this LEAD program, and it's kind of been a perfect storm of timing where it was like, oh, that worked out great, good thing, phew. I don't know how to pay for this otherwise, but it's all kind of worked out and come together.
John, talking about the IDN money, what specifically did you ask them to do for?
It was, so they identified that law enforcement assisted diversion, those individuals are typically really difficult cases that fall into the scope of what the IDN's trying to do. So it was kind of a brainstorming, how can we help? And I said, well, you know, the police want warm handoffs in the middle of the night, and we have to be there within an hour, which means I have to, like, have a dispatch service, I have to have people stipends overnight for this. So how can you help? So it was just a matter of, so they help with some of that funding for the stipends. So some of that, so it's kind of a mix, it's not all them and it's not all Wentworth Douglas, it's probably like a 50-50 mix to cover the cost of that. Because it's, you know, putting people 7 days a week plus weekends, 24/7, those stipends add up pretty quickly when you measure that over a year.
What are you paying for a stipend? How long is the shift? Is it 8 hours, 12 hours, 24 hours?
So right now, the stipends run for a 8 p.m. to 8 a.m. shift. And initially we did it at $7.50 an hour. We're changing that to, because it was like an hourly rate, and that's been a problem because you can only do 3 shifts. So we're shifting it to a $75 stipend, and then they get paid their hourly rate when they get dispatched.
Don't tell my coaches, we only pay 50, so.
All right.
I think Rebecca had one last.
I just wanted to pop in just in response. So there are actually 4 of the 7 that we're working with are using recovery coaches in the emergency department, and then I know the Dartmouth is. I just want to not belittle the point about the credentialing and the challenges with that, because it actually has to do with not just, it's not it's not put on just by the hospital, it's actually put on by the state, because even though as recovery coaches you can write a letter to the state so that, you know, regarding felonies, and still be a recovery coach, the hospital has to go through it again to get an exception for somebody who's having patient contact. Right. So a couple hospitals, the hospitals were able to work through that. That's something that I think that we all need to advocate to the state to somehow address. That, you know, it seems silly and redundant to the CHHS that, you know, somebody has to go through this process twice. And it is a significant barrier to credentialing for hospitals. So I just really, you know, I don't want people to believe thinking that this is a simple thing. Why aren't more hospitals doing this? It's very challenging. I just know that I just wanted to add to that there are lots of opportunities for recovery centers to be working with hospitals and connecting with community resources, developing harm reduction kits for people to go home with, lots of other things.
Thanks, Professor. So we're going to break up into groups of 5 or 6 with your neighbors, and we do have some flip charts and markers if something strikes you. So we have 3 questions for you to discuss with your groups. We have about 20 minutes. So just quickly, have you considered starting or have you started a program for recovery coaching in the ED? What have your challenges been in trying to start this program or implementing the program? And what strategies have you used to overcome or address these challenges or concerns? So we're hoping that you can have a conversation with your neighbors. And if you want to write down some things that you came up with in your groups, we will come back at the end for about 15 minutes to discuss what was discussed in your small groups, and then if there's any other questions for our panelists or for your colleagues around the room. And for those on the phone, Polly is going to be chatting with you all so you can participate remotely, and she can facilitate, report out, or any conversation for our remote participants. Thank you all so much.
Turn the chairs around.
She came and presented to us not that long ago. Love her.
Shift the discharge. But I mean, I think it's good.
Yeah.
So
I mean, we're using it if you lower that phone number.
Like it's different when you start off than it is like a talk. Stuff with some voices, like those slides, it shows the people, say, doing that, there's a different response. But then I've also been in a hospital, our staff was trying to do it, and the button doesn't go. So it's like, a lot of them are known that medication where they're not Well, they're saying that was like in they're lying, they're just making it up.
Right, it can't hurt. That's exactly it. And it's like, what have you got to lose? Where's the harm? Because it isn't about you, Anna. It's not about your decision form out. It's about saving this and increasing it. I get you're talking. I was you. I totally get it. And here's what I
and then the IDN, they obviously the IDN.
What if you and if it's not working, let's talk about it. Let's talk about it.
I'm writing now.
All right. So does anyone want to share what was discussed with your smaller group, with the larger group, for any feedback or conversation to share with the larger group?
Okay, so I'm gonna do.
As always, I think the question is sustainability. When we're talking about, this influx of federal and state money and time, and then it's hospitals.
All right, so you're all set up, right?
Yeah. Where am I going? I'm going to Harvard tomorrow. What time?
Margaret, you ready to have you know what's going on.
I mean, even providing a really informative cost-benefit analysis to the people that make the decisions with the money. If even, it doesn't mean that the money is just going to magically be able to appear or take over implementing these programs.
So our grant for the Lake campus ended December 31st, and the Franklin one goes into May. Yes. And so I didn't ask the hospital to pick it up. I went out looking for other grants to cover it, other, sources of funding. So it's easier for me to keep it going if, I don't have to ask the hospital.
So right now, your hospital pays nothing from this?
Say again?
Does the hospital pay anything towards this implementing the recovery touch program?
I mean, I would say just time, right? The time of people that, I don't reimburse myself on my spend.
It's part of your work.
Story, but no, we haven't had it. And I'm just saying to this group here that had we had to pick up the financial piece, we're not in a position to do it, so we could love it and be passionate about it as much as we want. We would not have been able to afford it. But I guess I'll just weigh in on sustainability. I always think, just like with diseases, the longer you live, the more chance there is that something else is going to be there, right? And so I think that, like, with Daisy's group picking up now where we left off with the foundation grant, and then the doorway coming in. So now we've got a couple of years, and then hopefully there'll be some reimbursement opportunities because this will catch on in the state and that sort of thing. So I think you just live for another day, until you can figure out what's next in order to sustain it.
I mean, that's the only cost I can go by. But I like your idea of doing the cost-benefit analysis, because from a hospital perspective, that would be important. And who knows, I think I heard you talking about if it saves staffing time in an emergency ED, maybe then hospitals can say, all right, I can divert some of that money over here, and that sort of thing. I think that would be important.
Another angle to take too is there's a lot of talk now around provider burnout, the medical field physician burnout, staff burnout, and there's a lot of challenge around working with patients with substance use. And so another angle we're taking is that this is a way for us to help address provider burnout by bringing in the right people to be able to provide the resources and so forth. And so that's, again, that's hard to measure, but it's another in the plus column of why this works.
Another cost benefit that's hard to capture is like how many cases of endocarditis are we preventing? Because that's a big bill, but until we don't know, because the person's in recovery instead of ending up in the hospital with endocarditis. So it's, it can do some cost benefit analysis, but there's a lot of unknowns that are huge benefits that we just can't capture.
I will say, if you're talking about funding, collecting data is really, really important, and just like you were saying about the endocarditis, but you can measure if you have this many repeat ED visits from so many folks, and has that decreased, since this program is in operation. You can't say that's an absolute correlation, but if we're seeing that in multiple hospitals, then we can make some assumptions, or at least the people who make decisions about funding can be swayed with those kinds of arguments. So data collection is important, and being able to capture these kinds of measures, and probably going forward having some of the same measures being measured in various places will also be helpful. And then the other thing I agree, and I think that the presentations here today displayed this beautifully. You give those numbers, but then you also give some stories, because that sways people who make decisions around funding as well. And then you need to get that information out. So it needs to go. Everybody needs to be. I have to be careful about my language, because you can't take state money and be advocates, but you can be advocates, you can't necessarily advocate for particular bills, but you can educate legislators. They make decisions about money. Governor and council, they make decisions about money. Governor's commission members, they make decisions about money. Those kinds of stories, in fact, in the bathroom, the two hospital reps and I were in the bathroom at the same time. And, and we're saying that you need to get that information out to folks. If the funders had heard what I heard this morning, we wouldn't be arguing about it. But as a person representing the state agency, me being able to share the information that I heard here does not have the power that you all have. So sustainability, and honestly, you live in New Hampshire. Nothing is going to be sustained with a guarantee beyond 2 years ever. So it is the way we operate, unfortunately. But I think to your point, this funding source may die and that one may pop up. Be ready to make a case.
Thank you for sharing what was brought up. Is there anything else that was brought up as a success or a challenge in either implementation or in just planning or thinking about implementation?
I have a little question. So for our presenters, the hospital piece, we're sitting in the hospital association building. Isn't there a group of higher ups in the hospitals that communicate more regularly in the state, or is that like ridiculous to even think? I mean, sharing with your colleagues, like, hey, this is what our hospital's doing, hey, they're doing it too, and then somebody might say, like, hey, we want to do that too, how do we do that, you know what I mean?
So as part of the project we have here at the foundation, we do have a peer network of the hospitals that get together that are working on these projects. We do have a few hospitals that are not supported through grants who participate in that. We just did had a special education session where we invited a physician from the Mid-Coast Hospital Main Emergency Department who's been doing inductions in the ED for a year and a half now, coming to do a presentation, and we reached out to a lot of other hospitals through that and are pulling them into our peer network through that. So yes, and it's still capturing somebody to have them come and participate in something like that is can be hard, which is cool.
What else? I mean, the room was loud. People were talking. Is there anything that anyone wants to share that they'd like to raise to the group, or? All right. I'm not gonna force you to talk. Does any of the planning committee want to say anything before I
I'd just like to ask one question of, well, we've already lost one of them, but, so for John then, in particular. When you are determining which of your many recovery coaches would be appropriate for this kind of a program, in addition to what was said, like they have to be able to pass the credentialing to the hospital, are there other things that either you consider in those choices of hiring a per diem coach, and or is there any additional training that they receive beyond what others do because of working in the ED?
Yeah, we're kind of headed, so our staff is all required to have a CRSW within 6 months of hire.
Yeah.
So a lot of them do, some of them are close. But the other thing that we've started to implement is motivational interviewing training. So we did like a training to have 6 trainers within our organization so that we can do it. So, as an organization, I think we're close to making MI a requirement for all our volunteer coaches, let alone for this. So I think, and I think just still, you have some people that are not comfortable going to the hospital. It's not that traditional wellness coaching, so to speak. It's mostly crisis, not for everybody. Usually I think, where it's staff only, it's pretty easy for me to identify that. And I've got some staff that have told me, like, I am not comfortable doing that. And then there's some staff that are like, I'm not comfortable doing it, but I want to get comfortable. Can I shadow you? Can I shadow Ashley? So right now, the way we are doing it, because we have like a separate SAMHSA grant under Goodwin that's doing a lot of criminal justice stuff. Ashley and Denny are doing most of that criminal justice stuff, and this has nothing to do with criminal, but because they're doing a lot of off-site coaching, it makes sense to have them, and Ashley manages the per diem staff because they're under that lead purview too. So again, I have to look at another side of this, which is the lead model, which is a harm reduction model, and people have to be appropriate for that too. So I'm kind of looking at it from a dual lens of it's not just people going to the hospital, it's people doing a warm handoff with the police departments in the middle of the night.
So people being comfortable and working off-site sort of alone.
Yeah.
People getting additional training, people being comfortable with the crisis model rather than a wellness model, and then also having some, I don't know that you use the term supervision, but working under someone else who has more experience in the same kind of thing.
Yeah.
So sort of.
Right. I mean, the whole crisis navigation is a pretty pivotal piece of this. So it's people that, the more equipped you are for that, and the motivational interview, like, I just feel like all coaches should have the MI. It's just there's such a big difference between coaches trying to save people and coaches using MI to shift that ambivalence, and that's just been a huge change for us, is integrating more MI training.
Thank you, because I think that other folks considering this.
What's been really cool too, I'll share, is like having a presence at the center, having a presence at the hospital, having a presence at the courthouse, and having a presence at the PD. People intertwine multiple programs. So it's like kind of being that connecting piece to like multiple different access points has been pretty cool.
Thank you.
Thank you, Lindsay. Well, thank you all for joining us today. I'm really excited that so many people came, and I'm hoping that you'll continue to come to our in-person meetings and participate remotely through the Google group. If you have any questions, it's not super intuitive at first, but I think it will be a good resource for everyone.
please fill out your evaluation if you want that CRSW or LADAC credit. And if, please fill it out so we can get your feedback. It does get looked at. We meet with the planning team after this meeting, go through that feedback, go through, debrief how this meeting went and how we can improve next time. So, I do have the dates for the next meeting. So if they're not in your calendar already, they're on our Center for Excellence website for this community of practice, but they're also right here, and we'll be meeting at the Nahatica Training Institute building for, in April. So
Please don't forget that there are these free medication disposal pouches. There's 2 cases back there, so take a handful back to your center. If you want more, reach out to me and I can get you some more.
Yeah, please take them.
thanks, everyone.
Thank you. Nice job, Melissa.
Good job.
Great, good job. I gotta tell you, on my laptop, before we turn off the lights in the corner, you were really good, and all of a sudden your face got just like, never red, and I'm like, what happened? I think I do the same thing.
Like, I'm happy I didn't have it right in the beginning, but like, I don't know what, I don't know. Yeah, but it's, like, and then it just stays a little bit when you start talking more, like, okay, I know, it's like my body, like, after doing this, it's like, all systems fail. But it helps to have notes for me, like, I like read, otherwise I always like, I never forget, like, what I either one of them. That's why it's always that's like a thing. Like our Irish was like, oh, I just take it yesterday. We're gonna put that call.
my favorites to make.
They're all gonna be there.
Yeah, how old is he?
What do you do?
No, because we, Rich, yeah, maybe.
So here's 11 son. So this summer I had kids, so I was doing my blood, right?
Say like,
Yeah, they're positive. I'm actually signed up, but it was so funny, it was right there, like, I'm like, it's selfie. So then, like, I feel like I have to return the paper, you know, and she's a funny picture of my face. Right. It's like right there, right. And that's where you were, that's where you talked about the faces. So thanks for asking, I appreciate it. Now, whatever the easy part. Yeah, they get more. Otherwise, I wouldn't, having to cheat, sit on your laptop, and get everybody all at once, like all those companies. No, she's near me. Oh, wow. Near me. It was by that paper, so my apartment is like, I was so down. So my definitely said, I know one hotline where you talk about my paper on my recliner or on my side table. She might hear something on the papers on the recliner. Yeah, my case is that. Makes a noise. You see that dramatic on let's have to get into my plan, somewhere. But I read that you have the directions of the process of the referral. I've been in the feeling. Really? Where do I park? Day one. And you did that for my
I don't know.
Harrison is where again?
I know that they're coming in and
Okay.
they dirt to you.
everywhere.
All over the
place.